Good evening and welcome to all of you. Hearty welcome to those who are joining from the East Coast, as well as those who are coming in from an afternoon time on the West Coast. Welcome to this tonight's session of CAEP National Grand Rounds. And we are going to have a timely and what I think is going to be a really informative and impactful hour together. In keeping with tonight's theme and incorporating a practice that I think you know is now widely embraced, I'd like to begin with a land acknowledgement. And in the spirit of reconciliation, we acknowledge that we live, work, and play on the traditional territories of the Blackfoot Confederacy here in Calgary, where I'm speaking to you from. That's the Siksika, Kainai, and Piikani nations, the Tsuut'ina and Stoney Nakoda nations, the Métis Nation Region 3, and all of the people who make their home in the Treaty 7 region of southern Alberta. My name is Eddie Lang, and I am the professor and department head for emergency medicine here at the Cummings School of Medicine and in the Calgary zone. I'm really thrilled to be your moderator this evening, and really am very excited to be part of this panel and program tonight. I am currently the academic chair, the chair of the academic section at CAEP, and also work at the Emergency Strategic Clinical Network here in Alberta. But let's get to talking about our two main presenters tonight. We have two phenomenal presentations. They're going to be about 20 minutes long, and that will hopefully give us ample time to have a 10 to 15 minute live Q&A session with our speakers. And if you have a question for one of our presenters, just type it into the chat and we will try our best to get to as many of the questions as possible after their two presentations. So just to remind you, CAEP's Scientific Planning Committee has reviewed each of the presenters' conflict of interest submissions, and neither of our speakers have any potential conflicts of interest. And there has been no external support provided for the creation of this webinar. So without further ado, let's go to it. Our first presenter tonight is Dr. Patrick McLean. Patrick is a health services researcher. He holds a PhD in sociology from the University of Alberta, and as an adjunct professor of emergency medicine at the University of Alberta, he has developed a mixed methods program of research that you'll hear about tonight, examining equity in emergency care. I get the privilege of working very closely with Patrick. He is the assistant scientific director of the Emergency Strategic Clinical Network at Alberta Health Services. And then after Patrick gives his talk, we're going to hear from Leah Bill. Leah is the executive director of Alberta's First Nations Information Governance Center. She's a registered nurse. She's of Cree origin, originating from the Treaty Number 6 Pelican Lake First Nation in Saskatchewan. She's worked in the health field as a community health nurse and Indigenous knowledge holder researcher for most of her career. So huge welcome to our two presenters. Very fortunate to have them with us. And I will turn things over to Patrick. Please go ahead and you can start your presentation.
Thanks very much, Eddie. I'll share my screen now. So you should be able to see that. And I'm really pleased to be able to present with Leah Bill, who Eddie had introduced. We're going to talk about a project that has been ongoing for a number of years in Alberta on quality of care for First Nations members in emergency departments. We started this in 2016. So Leah, would you like to just put your camera on and greet the audience?
Yes, good afternoon to everybody. And I'm very happy to be part of the presentation and look forward to any questions and comments, and appreciate the opportunity to present our work to all of you folks.
Thank you, Leah. And so disclosures, I am an employee of Alberta Health Services. Leah, of course, is an employee of the Alberta First Nations Information Governance Center. Each of us has received grants from the Canadian Institutes for Health Research, which funds this program we're presenting today. Here's our funder. Of course, we have research ethics for this mixed methods project. We want to talk about how we mitigate potential bias. So neither the funder nor Alberta Health Services have had any role in the design or conduct of this research or reporting or interpretation of results, although our colleagues in AHS at the Emergency Strategic Clinical Network and Indigenous Wellness Core are very supportive. We also mitigate bias through our engagement with community partners, who we'll talk about in our Elder Advisory Board, so that we're really validating what we're saying. We have objectives for this session. So we'd like you at the end of the session to be able to understand the political and policy considerations which lead First Nations people to rely on emergency departments disproportionately more than others. We want to identify stereotypes and barriers impacting First Nations members' emergency care. And we want to focus on some strategies that we've heard that some providers are already doing, and what departments and health systems can do to improve care for First Nations members. And Leah and I will both be speaking through the slides. And please jump in, Leah, at any point. So we wanted to talk about, oh, sorry, Leah, were you going to say?
No, I'm just saying, yeah, concur.
Thank you. So we want to talk a bit about your CanMed's competencies. We were asked to do that as part of the presentation. So we're going to focus on two. One is communicator, so looking at building rapport, trust, understanding patients' life contexts, shared decision-making, culturally safe discussions, and thinking about social determinants of health. We'll also talk about your role as advocates, so partnering with patients and populations to call for systems change. As we go through, you'll see a need for system change. And developing partnerships with support networks or community organizations and agencies. So that can be First Nations organizations. These are our partners. So really privileged to work with First Nations organizations from around Alberta, the Treaty 8 organization, Yellowhead Tribal Council, Musqueam's Health Services, Blackfoot Confederacy, the Stoney Nakoda Tsuut'ina Tribal Council. Obviously, those aren't all the organizations, but we do have important organizations from around the province. The Alberta First Nations Information Governance Center, UAlberta, also colleagues at UCalgary, Alberta Health Services supporting, and Alberta Health has provided data for the project. This is our team. We won't go through everyone, but we are really glad to have this strong team. Bonnie Healy is a member of the team and has experience as an emergency nurse, while Brian Holroyd, who many of you may know, is a professor of emergency medicine. So we have those clinical perspectives on the team. We also have an elder advisory, and I invite Leah to speak to the importance of our elders.
Yes, the elder advisors have had direct experiences with emergency care, but they're also utilized on many other committees as far as research is concerned. Leonard Bastine, for example, sits on our board of directors as an elder advisor. Helen Bull is quite actively involved at Musqueam's Health Services, as well as Mary Crawler in her community in Bighorn. Tina Jacobs sits as an elder advisor with the Stoney Tribal Council. And then we have Lena Firth and Ochis and Dustin Twin with Treaty 8 organization. These elders are very actively involved in a lot of different health projects. And so they're very instrumental in making sure that our work is reflective of what communities' values and principles and their experiences are.
Thank you, Leah. We wanted to acknowledge as well people who've worked on coding the data with us for the qualitative findings, and the statistical analysts through Dr. Rhonda Rosachuk's Biostatistics Consulting Group. And I'd ask Leah to speak to this slide.
Yeah, I think most likely many of you have had some level of experience with OCAP. these are formal research agreements that we have with academics as well as academic institutions as it relates to any research that's being done. It specifically outlines specific roles and obligations as it pertains to OCAP. If an IGC is the qualitative research data custodian on behalf of communities, and where communities have the infrastructure in place to hold their own data, of course they do. The communities own the qualitative data, and we are primarily the custodian for it. The elder knowledge holders, as well as the key community members, health directors, are part of co-interpretation of project data and the production of the results in the end. Earlier on in our work, of course, we really tried to utilize a Indigenous knowledge research approach. And so as a result of that, this process came into play utilizing circle technology, or talking circle format. And this not only allows for people to have equal opportunity of expression of their experiences, but it creates an ethical space and allows for healing also to happen, and reconciliation. And I think that's one of the biggest things around this work is there has been a tremendous amount of reconciliation and open discussion and revelations around really what needs to happen for systems change. So the research process itself has been very much guided by ceremony, ethical accountability, and creating a sense of safety, especially around discussing these very difficult conversations. It supports the power balancing because sometimes people feel intimidated not to actually say or state what has been their experience. And like I said earlier, promoting healing and reconciliation, we found this to be very helpful for those people that didn't feel like they had been heard, or that their experiences had no mechanism or way of reconciling on their behalf.
Thank you, Leah. I couldn't stress enough how important this has been. We wouldn't be able to do this work ethically without the partnerships that we've had. So we'll talk a bit about some of our descriptive results. This is one of our first published papers. We have data for 111 facilities in Alberta, over 11 million visits in that data set. And what we saw is over the 5-year period, we have data for Alberta health statistics, which show status First Nations person as 4% of the population. We know that's an underestimation, but that 4% of the population had almost 10% of all the emergency visits in the province. So we know emergency care is an incredibly important health service for First Nations people. This slide shows population rates of use of emergency department around the province. And what we see is this isn't just an urban issue. Edmonton, Calgary is not just a rural issue. All over the province, First Nations people are using the emergency department more. So it's the rate per person. As a non-First Nations person, maybe I'm using the emergency department every 2 years or half a time a year. First Nations people at a population rate during the ED 1.5 times a year. So we would link that to lack of access to quality primary care. That's been widely talked about and reported. Josie Lavoie has done a lot of work on that. In the National First Nations Health Survey, which Leah's group is part of, 22% of adults, 22.6% of adults in 2015, 2016 said that there wasn't a physician or nurse available in their area. And so what are the reasons for this? One is policy and legislative issues. The Indian Act makes First Nations health a federal responsibility, while the Constitution for Canada would make healthcare a provincial responsibility. So this results in First Nations people being left in the jurisdictional gap of accountability. In 2011, the Auditor General of Canada has said that there is a lack of evidence that the government of Canada is committed to providing services that are comparable in range to what we enjoy elsewhere in Canada. The Auditor General noted that the government hadn't written itself any laws that say they're obligated to do that, and had highlighted that funding mechanisms for healthcare shift burden of providing care onto communities. In 2018, the Auditor General had presented to Parliament and said that after 7 years since this 2011 report, with other reports in the interim, the situation as it exists was beyond unacceptable. Leah, would you like to add here at all?
Yes, for sure. And I think that, the circumstances that have been reported and really been high in terms of the in media reflect exactly what the Auditor General of Canada has been found lacking. And it's unfortunate that, it's taken deaths and these situations to happen to actually bring it to the level of attention that we now have on this situation.
So we've asked that as emergency physicians and nurses, you would understand the high proportion of First Nations visits in emergency departments, not as about the choices that individual First Nations patients are making, but about this gap in other quality health services, leaving the ED as the place where care is accessible. And so we would see that you, with your associations and colleges, can be allies with First Nations in demanding change. We do want to share that in the work we've done, First Nations patients have talked about good experiences in emergency departments. Of course, it isn't all negative. Some had a lot of empathy for working in emergency department as a very difficult job. And so we'd ask that people bear that in mind. And then we are going to focus a lot on the negatives for the remainder of this presentation.
Well, and I think the other part of that is, while we're presenting really the stark negatives, like Patrick has said, there are care providers within the emergency setting that really do try to do their best. But I think the key part is that the seekers of care also understand that working in an emergency care situation is challenging at the best of times, because people are coming there for help that are in serious conditions. So I think that that's another piece of the story or the narrative that needs to be considered.
That's right. And we'll talk later in the presentation about what systems can be doing to support providers. So we'll talk about our qualitative data. We've got our first publication was based on sharing circles with 46 persons from all around the province. We also have data from our ongoing project where we've had sharing circles in Treaty 6 and Treaty 7. We've talked with health directors from around the province, and we've interviewed physicians and nurses. And so it's quite a robust data set. On average, the physicians and nurses had 90-minute interviews. We're really grateful for that. And the sharing circles are all-day events. So all providers that we spoke to acknowledge that there is racism in emergency departments and stereotyping in the ED. And people stress that that's because ED is not separate from society. Anything that can be happening in our society is going to be happening in emergency departments. At the same time, some providers stress that emergency departments can be a hotbed of discrimination. The work is difficult, it is time pressured, patients aren't at their best. And we heard about specific stereotypes. Now there's a number of stereotypes, and these might be the top three we heard about impacting care in emergency departments. One is this idea of First Nations people misusing or inappropriately using the emergency department. Now, again, you can see how a lack of primary care, if that's not understood, that could reinforce this stereotype for people. Also stereotypes related to substance use, alcohol and other substances, and stereotypes of First Nations people as bad parents. This is a quote from a physician. The physician says, "I would definitely see a bias against the First Nations. You have this terminology of," and this is the provider's words, "drunk Indian, what's in bed 6? It's a drunk Indian, you don't need to go in." And what we've done now is we've put together the pathway from the stories, the individual stories that we've been told from physicians and nurses and First Nations patients. We've woven together to sort of illustrate all the places where care and care seeking can break down with barriers. So we heard from people that they're avoiding care if at all possible. Past negative experiences lead people to avoid care, including emergency care. If seeking care for a child, we've heard people worry about having to encounter child services. With 70% of children in custody in Alberta being Indigenous, you can certainly understand people's concerns. We heard that people will choose the ED as the only care option if they're coming to ED. They're thinking about, do I bring an advocate to try and get better care? And we heard from people all around the province that they'll bypass their local hospital because of bad experiences that they've had or that people they know have had, and they'll be driving longer distances to try and access another hospital, which is obviously a problem in an event of a medical emergency. This is a quote from a health director who says, "So the community will sometimes see patients at the health center wanting to see a nurse, but really they should have seen a doctor, and they're referred to a doctor like to go to Emerge, and they're like, no, I'm not going." A family physician who works in a nation had disclosed to us that they actually tell patients to avoid the nearest emergency department when having emergencies and drive further in order to try and receive better care. So a major system dysfunction. This is a quote from a nurse, a First Nations nurse who participated in one of our sharing circles. And the nurse said, "My dad was there. We decided he should stay home just because I'm passably white. People don't automatically assume I'm Indigenous when they see me, so I often get treated better than when I'm with my darker family members." So this is not something I, as a white person, am having to worry about. If I have a negative interaction with someone in an emergency department or elsewhere, I might think that they're very busy or that they're not very nice. I don't have to worry about the specter of racism. We heard about people being told at registration or triage that there's nothing wrong, they don't really need to be there, which could cause someone to leave care. We heard from a health director really articulately talked about the negative impacts of seeing other people, especially if you don't understand triage, seeing other people, white people, treated more kindly or seen faster. This is a quote from a nurse who we'd interviewed, and this nurse says, "I would say as a general rule, as soon as we hear that there's an ambulance coming in from a nation and they named a specific nation, there's an assumption it's going to be something silly coming in. So we see this bias. The patient hasn't even arrived yet and the system is gearing up. It's in some people's mind that this isn't going to be an emergency." This is a quote from a health director again. "I don't go just for nothing, and that's how they've made me feel, like I'm just there for nothing." And a couple of times they had actually mentioned that, it's a lot of resources that are being used here. Just this kind of like I was wasting their time being there. And so then moving through our patient's journey, they may overhear staff talking derogatorily about Indians, as we saw in the first quote, using that old-fashioned language, using the S word derogatorily about Indigenous women. We have a quote about a patient overhearing people making fun of their Indigenous name. Then the patient has to speak up and have a negative interaction, or say nothing and feel badly about not speaking up. And patients at any time they're encountering a negative experience like this are thinking about leaving without care or staying and hoping things will be okay. And this is the quote I mentioned. Patient, really lovely woman, she said, I was on a gurney in the hallway, and then they asked for my information and stuff. Then they went away, and I could hear them making fun of me, making fun of my name. These were the people that were supposed to be taking care of me. I regret to this day not speaking up. And that strikes me, the regret, the patient still thinking about it. Janet Smiley, Kitchling, and colleagues have published just recently that patients who've ever experienced discrimination in healthcare are much more likely to later have unmet healthcare needs. So these interactions, they have long-term impacts for the patients. And we know that First Nations visits in Alberta leave more often without being seen than non-First Nations visits. And that's been reported actually for Indigenous populations all around the world, in Australia, New Zealand, the United States. Leah, would you like to add anything?
Not at the moment. I think we can move on.
Thanks, Leah. So I know this is hard, but we want to share what we've found in our research. So we heard that physicians will often assume substance use. Patients had stories of that. Or we heard that stereotypes of substance use could cut the other way. Patients talked about being offered opioids, where people assumed that's what they wanted. We heard issues around communication, where the patient might realize the physician thinks that they're not intelligent because of their appearance or way of speaking, that physicians might be annoyed by their questions. And we heard from many, many people who came to our sharing circles about receiving no tests or treatment on a first ED visit and having to go back again, maybe multiple times. So this quote, the patient talking about their sister, she says, my sister called the ambulance and she went to the local hospital and the doctor told her, are you here to get some pills? And she said, no, I'm sick. I need to know what's wrong. And the doctor told her, why did you call an ambulance just to come and get your pills? And he was mad because she took the ambulance there. When my mom got there, she said, can't you tell? Look at her face. There's something wrong with her. So my mom had to raise hell with the doctors to get her checked. She had had a stroke. Here we have a quote from a physician acknowledging some biases they had. The physician says, I had a patient who had, a definitely audibly First Nations way of speaking, right? I became aware she was actually a university professor. I was surprised by that. Another physician says, that slow cadence that the physician associates with First Nations is probably annoying or a negative feature. And health director speaking to the impacts of these interactions. That confidence and that knowledge that we've built up is dismissed because of the color of our skin, or because of how we speak, or because we have an accent, or because we don't have all of the technical jargon down. And then we heard many accounts of patients saying, and physicians and nurses talking about cases where there would be less thorough investigations, rough physical handling, misdiagnosis, missed diagnosis, delayed treatment, lack of needed treatment, inappropriate treatment, or harmful treatment. And then the barriers don't end at the end of the emergency care visit. Patient may have to wait outside for pickup if they're waiting for medical transport or if they're waiting for a relative. We heard of patients being asked to wait outside the hospital saying they're not allowed to wait within the premises. We heard patients talk about returning to ED after days or hours at home, potentially receiving serious diagnosis and referral to further care. And then encountering barriers to follow-up care related to transport, discrimination, and communications, and patients continuing to use ED whenever other care options aren't available. So quotes around this, a health director saying a lot of time people are discharged and they're not sure what to do, and a lot are scared to ask questions. Here are physicians speaking to barriers around transporting communication, and we can't give all of the examples, I wish we could, but the This quote is, "I found that patient specialist follow-up appointments get canceled because of transportation issues. And then they get like banned from that specialist's office. They're like, don't refer to us again. They had too many no-shows." And it's like, poor guy, he doesn't speak English. The van broke down. They couldn't get there. Like, they're not trying to waste your time. So we want to raise awareness around some of these issues and think about what systems can do to ensure continuity of care for patients. Changing the experience. We heard a lot from patients, but a desire for providers to know colonial history and determinants of health, what's in patients' control and what's outside their control. And that includes locally, so the history in every local area is going to be different and unique. We heard about a desire for equity approaches, especially around medical history, around drugs and alcohol. So it could be, instead of saying, when did you have your last drink, which is going to be very triggering given the stereotypes, you could say, I would ask any patient with your symptoms about drugs and alcohol, could I ask you questions about substance use? It could help me provide the best care for you. We heard about the desire for creation of ethical space. So coming together, recognizing our shared history, recognizing we're already in relationships with one another and building those relationships. And systemic
Maybe
approaches.
I'll talk a little bit about the ethical space. And,
thank you, Leah.
Irma speaks about ethical space as when you come to any space, especially as we can think about ourselves as healthcare providers, we should be leaving our biases at the door and not allowing that to interfere with our judgment or even our care provision. And I'm having been a nurse for over 40 years and worked in many different communities in Alberta and the Northwest Territories. I understand what it's like to work with multiple ethnic groups or different cultures. And, it is challenging, especially when somebody is different. But, I think that this principle of ethical space needs to be really considered in certain environments. And as healthcare professionals, we develop a certain level of arrogance at some point where we think we know more and better than the presenting seeker for care. So I think that this is a really important concept that needs to perhaps maybe be looked at within the emergency department as a whole, because it's supposed to be a safe environment where all people seek care and intervention for real serious illnesses.
Thank you, Leah. And so we'll finish with our recommendations, and we're going to have those at the provider level, at the department level, individual emergency departments, and for systems. So we're asking to treat each patient as a unique individual for purposes of diagnostics and decision making. So not letting that diagnosis get short-circuited with preconceptions, conducting complete investigations at each ED visit, learning about and reflecting on stereotypes and biases that we're trying to speak to today so that you could self-correct during care encounters, learning about the history of First Nations and colonial history, including locally, recognizing that resources outside the ED are not always the same for First Nations patients as for non-First Nations patients. So the follow-up care pathways may not work, especially around primary care access and transport. That First Nations patients often have past negative experiences with the healthcare system, and that stereotypes can be activated by your words or actions, regardless of your intent. So it's not about people intending to be racist. It's about how the patient experiences their care as culturally safe or not. So thinking about how could care plans be modified accordingly. And we heard a lot of examples of how individual providers are doing things like that. Maybe making sure that a patient who has food insecurity is getting food when they come in for a dressing change in a rural ED, maybe keeping a patient who has transport issues overnight so that they do get to see the specialist the next day. So then what can be done at department levels to support you to do that. And we'll get to that with recommendations. But we also heard an awful lot about the importance of taking time for First Nations patients. So this is a physician quote, and many physicians and nurses talked about this. The physician says, you hear, oh, this patient is refusing their blood work. This patient doesn't want to stay anymore, or whatever it is. And so instead of just saying, well, screw it, I'll go back and have another conversation. I'm not going to do that kind of song and dance with every patient, but I will do it with patients where I think that there is a history of poor interactions with the system. Just another quote on the same theme from a health director saying it's taking the time to listen to what is wrong with the client. For departments, take for granted that racism impacts health and healthcare. So not every department has to do its own study. We know it exists. Develop training on local resources, services, and funding sources available for First Nations patients, and not just training, but having the book of what the services are available so it's easily accessible for you as providers. Looking at standardizing care and discharge pathways to address social determinants of health, some of those transport barriers, primary care barriers, to get patients connected to care. We think that's department level work. Not every provider can do that on your own. We're suggesting that departments build formal relationships with First Nations communities to familiarize providers with the realities that First Nations patients face and the resources that are available, and enable the ED to understand the First Nations communities or the community health services expectations for emergency care and starting to work together. A health director says, reconciliation in emergency departments would have some communication and stuff with the nations or First Nations health directors working together on what we're doing. It's starting to plan together, advising us on their, or adding us onto their committees, like their boards, having some Aboriginal representation. And for health systems, create safe and well-moderated ED specific training opportunities, like we're doing tonight, to help providers identify prevalent stereotypes of First Nations patients and develop anti-racism skills, like how to speak up if you witness discriminatory comments. Ensuring processes for reporting and restorative follow-up of racist behavior, and protecting the person who's reporting that. So not putting patients in a position of having to prove that someone was racist towards them. Promoting education on First Nations languages, English dialects, communication styles, and behavioral norms. And then creating standard forms, planning documents, and information resources and other tools to facilitate all of the recommendations that we've had for providers and departments above. And so I would ask Leah to then make final comments.
I think overall, the research that we've done now provides the evidence that we've been talking about for a very long time. Like, I think as Indigenous healthcare providers and Indigenous people, we have been saying for a very long time that there is no equity within the system as far as primary care is concerned. And even, for example, this one topic around the experiences that are being had at the emergency department level. The evidence speaks very clearly and loudly that the system is not providing the services that are needed in the best way possible. Particularly now, at this point in time where Canada as a whole is being called to task around reconciliation and truth of its own history. This research really does support the need to take some action in a meaningful way. And really, some elders have said, it's not our job to fix a system. It's the system holders need to make the effort to bring the change. And, you know, who are we accountable to in the end? And who is the system accountable to in the end? And each one of us as healthcare providers and health professionals, we wouldn't have a job without these people asking for help. And I think we forget about that. We forget that we're in service to people. We're not in service to a system. And if the system doesn't help us to do the best job possible, then it's incumbent upon us to try to make those changes. Otherwise, we're part of the problem. So, you know, really, that's all I have to say. It's disheartening in this day and age with all the technology and the investments that have been made over the years that we still are experiencing this very poor care for a certain population.
I want to thank both of you for this really powerful presentation and really congratulate you for this unique collaboration. And by doing this research, I think you have really brought forward the key perceptions and issues that really frame this issue, the problems that we face in emergency departments. So thank you so much for that, and of course, thank you for your time. We have we're just waiting for some inviting questions from the audience. We had a solid turnout tonight. Just maybe people are just reflecting on what the powerful words that you've shared with us from patient and family experiences. Maybe just to get things started, one thing that comes to mind, your recommendations resonate and seem and are certainly logical and robust, but do you have some experience with, you know, specific emergency departments that have done things that you would say have made a positive impact and have really changed the culture, I guess, if you will, of the emergency department and the emergency department staff? Has anyone, what would be the key ingredients and what departments can do to maybe correct this and get this right? I don't know, Patrick, would you want to start with that, or Leah, would you like to?
I'm not aware of a department that has done this. I know there are people working very hard in many of the departments around the province. I think key ingredients would be the partnerships, formal partnerships, so that things are co-led with First Nations, whether that's urban communities or an on-reserve community that the department serves, and has a real co-leadership model like we have in this research. We do have colleagues in British Columbia who have an equity-oriented program of research in several emergency departments to look at care for First Nations members. That's Annette Brown and Colleen Barco. Their work is fantastic. I'd encourage people to look for it. But I think we'd like to be part of building the partnerships to really start doing intervention research for anti-racism in emergency departments, looking at things that can be done around continuity of care, what can we do around transport issues, really supporting patients. Leah?
Yeah, and I think another real key ingredient is at the systems level and professional level, College of Physicians, I know with emergency physicians, etc. You're in key, powerful places where you can really start to think about where you can create those partnerships or even become part of the solution as opposed to just standing by. I know we didn't really speak a lot about how certain like whistleblowers are not looked upon kindly. And so this is one of the reasons why people are not speaking up and they're not taking action, because you belong to your own culture. we have our own professional cultures and we belong to those organizations as well. So it becomes really challenging. And I think we have to look at that. Nurses and physicians and managers and directors, we all have to look at how are we contributing to the problem, and to really take the time to reflect on that. And you know, we have to ask ourselves, why are we as a developed country still faced with underdeveloped conditions for First Nations and Inuit and Métis folks who, are not receiving the care they need to be healthy.
We have an attendee calling in from Quebec, and that person is, of course, highlighting the tragedy of Joyce Echaquan and what occurred to her, with her in the hospital. And this person's wondering if the Joyce's principles that came out of the reports and the attention that case received, whether some of those can be maybe highlighted and maybe hold the most promise for addressing systemic racism.
Yeah, I think Joyce's principles, I thank you to the attendee for highlighting those. I think, the report of the murdered and missing Indigenous women in Canada, their final report, the United Nations Declarations for the Rights of Indigenous Peoples that says Indigenous people should be directing the health services that they receive and that are paid for to serve their populations. I think that we could look at the Royal Commission on Aboriginal People from the 1990s and the recommendations there, the Truth and Reconciliation Commission of Canada's report. So there are a lot of good sources to draw on. The BC report on anti-Indigenous racism in healthcare. There are a lot of good documents that we can draw on. I think what we need to do is build the ethical spaces and the work together. And I really, Leah, I should let you speak first.
Yeah, no, that's true. Like there's copious amounts of documents and that speak to this, as to the need to have equity in decision making and also in delivering of services. At the very beginning of our presentation, we talked about jurisdictional issues and the misunderstanding, or everybody has their own idea of who's responsible for Indigenous health, while at the same time the regulations and the policies that are in place are not supportive. They're actually fragmenting the capacity and ability to deliver services the way they need to be across the board. So we can come up with more principles, but it's about the commitment and the willingness and the readiness of the system itself to really invest in that change, and to have this vision of having an equitable healthcare system, and not always to talk about or bring up the cost. If we want to have a good system, it's going to cost. And right now it's costing us lives. And it's disabling Indigenous people to actually be a part of the society in a constructive way, in a way that they're contributing. We're very, if we go back in history, Indigenous people have always been a part of building the nation. We have not been a part of taking down the nation, but the way the systems are generated and created, there's been a lot of exclusion, and we've always had to fight to be part of any constructive building of system.
Thank you for that, Leah. Michael Cruz is wanting to know what is the experience and if there's a role for either traditional healers to be based in the hospital and the emergency department, or just dedicated advocates for First Nation people, so that there's not necessarily reliance on family members, which I can imagine even in the COVID era is even worse because of the restrictions on visiting. So I don't know if who would like to maybe take a
Yeah,
start at that.
for sure. I think that that's a really good point that you raise. It's been discussed many, many times, but again, we keep running into the wall. First of all, the system is governed by a colonial system that doesn't actually allow and permit Indigenous healthcare practitioners to be part of the system. So it's always talked about as, well, they can be, or the doctor themselves don't recognize the value of a traditional practitioner, even when they do run into problems and issues with a patient or a client. They're not willing to make that referral. And so we don't have that in place. And in our cancer research, for example, it's being raised time and time again, where patients are desiring to follow a traditional treatment pathway, but then they're told in some cases where if you're going to do that, then you can no longer be my patient. So there is a need here to build those partnerships between Indigenous practitioners and the doctors and nurses that work within the system that are regulated. We're regulated too as traditional healthcare practitioners, but in a very different way. Our system is quite what we call it. It's strong too, and we're accountable, and we have our own way of being accountable and being accounted for, just the same as the Western system has.
Yeah, and on the piece of and I think we couldn't put everything in the presentation. We did hear a lot about how people value ceremony and traditional healing practices in our research. On the piece on cultural liaisons, I think that's an important role. I think it would be a very difficult job to be a cultural worker, an Indigenous person dedicated to Indigenous issues in a hospital. I think you'd never have enough to handle all the issues. And I think that a really great role for people with those jobs could be helping physicians and nurses to have processes and ways of practicing, so that when the cultural navigator isn't there, the physicians and nurses have some tools in the toolbox.
Well,
Thanks,
and I
Patrick.
think one of the things, as Patrick mentioned earlier, a recognition that a non-Indigenous person doesn't have to consider the same things that non-Indigenous people consider. Like, I know we didn't talk about, even people will go out of their way to present themselves so they don't get discriminated against, so that they can actually get the care. They will dress up, some of them, but if you're really, really sick, and you go there, you go as is. But that's sad when you hear stories like that. And with COVID, it's made it worse, where people are literally met at the door and say you can't come in if this and this and this. So it's been exacerbated by COVID in a lot of ways. And again, when we're in the front line, I don't think it's incumbent on us to turn people away. That's, again, it's about ethics. But COVID gives you permission to do that, I guess.
Well, on behalf of the emergency medicine community and CAEP, I just wanted to sincerely thank both of you for shedding so much light on this issue in a really unique and powerful way. There's so much that we have to do, but it has to start somewhere. And I'm hoping that this presentation will get the many balls rolling, if you will, and get a number of emergency departments and groups thinking about these issues and how to address it through the variety of recommendations that you've made, and even leveraging simulation technology and other kind of novel ways to ultimately change the culture that we know exists and so pervasive. So we just have a couple of minutes left. I don't know if you had any closing thoughts or messages for our audience before we sign off.
I would put a plug in. We have a paper from this study coming out in the Canadian Medical Association Journal that is on triage of First Nations persons. That will be released on Monday. It's under embargo by the journal now, but please look for that. That'll be coming out. And I'd really like to thank Eddie and CAEP for organizing and having us present today. I'm really grateful. Leah?
Yes, I concur. I really appreciate the opportunity. I know it's a difficult topic, and we've tried to raise the awareness and to really get people thinking and reflecting on what role or how can they be a part of changes and bring solutions rather than just being stuck, because I think we've been stuck for too long. It's time for change now, and create something that we can be proud of here in Canada.
Those are phenomenal final words and thoughts to finish on. Thanks again to Gail and Jeff, Alan, for helping put this all together. All the support from CAEP has been amazing. Thanks to all of you who joined us tonight and for your great questions. I know these are challenging times for emergency medicine, and so I'm wishing everyone who's out there good health, safety, and hopefully a very, very prompt resolution to this fifth wave, and we'll hopefully very shortly be on the other side. So thanks, everybody. Have a great night.
Thank you very much, everybody.